Hello everybody. Today we are going to discuss about the physiologically difficult airway. So difficult airway is defined as one in which patients' physiological and pathophysiological alteration increase the risk for complication during tracheal intubation and transition to positive pressure ventilation. So contributive factors are pathophysiological alterations such as hypoxemia, cardiovascular instability, right ventricular dysfunction, and increased intracranial pressure, as well as physiological alteration that occur in obesity and pregnancy, contribute to physiologically difficult airway. Environmental and the human factor, in addition to the patient's physiological derangement, contribute to the increased risk of complications during management of the physiologically difficult airway. The likelihood of encountering patient with physiologically difficult airway is higher in the intensive care unit, emergency department as compared to the other location in the hospital. Now about team preparation and the human factor consideration. An appropriately designed intubation checklist that address the equipment, drugs, team rule, composition, patient optimization, and both primary and backup plans for airway management can reduce the error of omission and may improve patient outcome during management of physiologically difficult airway. The intubation team should consist of at least three healthcare providers during the management of physiological difficult airway, and this should include two airway operator and at least one of whom should be experienced. Then assigning role and responsibilities of the team member, ensuring the shared mental model among team member, discussion of primary and rescue plan, and gathering and interpreting information, as well as anticipating problem that can improve team performance during management of this situation. Post-procedural team debriefing can help improve team performance and for the future management of the of this physiologically difficult airway. Then training requirement for provider performing airway management in patient with physiologically difficult airway should be well defined. Simulation-based training should be a part of the curriculum for provider performing airway management in this patient. Then about assessment and counseling, critically ill patient requiring tracheal intubation should routinely undergo pre-procedural airway assessment to screen for potential anatomical and technical difficult airway. Screening tools that assess the factor beyond predicted anatomical difficulty, such as MACOCHA and the HYPE score, may be used to identify patient at risk of this physiologically difficult airway. Patient with this physiologically difficult airway should be counseled about airway management prior to the intubation if feasible. About hemodynamic monitoring and optimization, the minimum mandatory monitoring in patient with physiologically difficult airway undergoing tracheal intubation should include non-invasive blood pressure, continuous ECG, and pulse oximetry. Hemodynamics should be optimized prior to the tracheal intubation in patient with physiologically difficult airway. Interventions such as vasopressor or inotrope infusion administration can help prevent and minimize peri-intubation cardiovascular collapse. Use of the peri-procedural point-of-care ultrasound, when feasible, can improve safety of this tracheal intubation by aiding assessment and management of cardiorespiratory compromise. About Makocha score. Makocha score M stands for Malampatti 3 and 4. Total score allotted is 5. Obstructive sleep apnea 2. Cervical spine movement limited 1. Mouth opening less than 3 1. Coma 1. Hypoxemia less than 81. Non-anesthetist intubator 1. If Makocha score is more than or equal to 2, then that predicts the difficult airway and we need to call for the senior anesthetist for managing the situation. Then about oxygenation and respiratory optimization. Pre-oxygenation with the NIV is the preferred method to minimize the risk of oxygen desaturation during tracheal intubation in patient with physiologically difficult airway. Apneic oxygenation using high flow nasal oxygenation is acceptable technique to minimize oxygen desaturation during tracheal intubation. Careful mask ventilation may be performed during apneic phase of rapid sequence intubation to minimize desaturation. In patients with physiologically difficult airway who are difficult to pre-oxygenate due to lack of cooperation, the benefit of sub-anesthetic dose of sedative hypohypnotic while preserving spontaneous ventilation, that is delayed sequence intubation, may outweigh the risk. Head elevation of laryngoscopic position, also known as semi-follower, semi-fowler position, with head of the bed elevated to 30 degree, should be used for tracheal intubation in this patient. Now about performing the procedure. A modified RSI technique, that is titrated administration of rapid onset of sedative and hypnotic, rapidly acting neuromuscular blocking agent, and gentle mask ventilation should be considered in patients with this type of error to prevent peri-intubation complications. Cricoid pressure should be released in case of difficulty with visualization of the cord during tracheal intubation in patients with physiologically difficult air. Ketamine and etomidate are the preferred sedative and hypnotic drugs for tracheal intubation in patients with this airway. Standard anesthetic induction doses of propofol should be avoided in patients with this airway to limit the risk of periprocedural cardiovascular collapse. Ketamine is safe to use for tracheal intubation in patients with physiologically difficult airway and suspected or proven intracranial hypertension. Succinylcholine and rocuronium are preferred neuromuscular blocking agent during tracheal intubation in these patients. Succinylcholine should be avoided in certain situations, such as patient with skeletal muscle myopathy, known allergy, history of malignant hyperthermia, hyperkalemia, and significant burn injury. About tracheal intubation, video laryngoscope should be available during tracheal intubation in patient with this airway, and all operators should be trained in the use of video laryngoscopy. Video laryngoscopy should be routinely employed during first attempt at tracheal intubation in patients with this airway, as it enhances glottic visualization and is superior to direct laryngoscopy in difficult airway management and aids in the supervision and assistance of airway operator by providing shared view of the glottis. A stellate and the bougie should be used routinely while performing tracheal intubation using either direct and video laryngoscopy in this patient. Now about post-intubation care. Immediate post-intubation care of the patient with this physiologically difficult airway includes confirmation of position and securing tracheal tube, management of cardiovascular instability using pressor or fluid as appropriate, and any other condition. Tracheal placement of the tube should be confirmed using waveform capnography based on consistent rise in amplitude of end-tidal carbon dioxide during exhalation and will decline during inspiration over at least 7 breaths. Chest auscultation, chest X-ray, and bronchoscopy are acceptable methods to confirm optimal depth of the tube in the trachea. Then about ventilation and hemodynamics, lung protective ventilation strategy, including tidal volume of 6 to 8 ml per kg of predicted body weight, positive end expiratory pressure of more than or equal to 5, plateau pressure of less than or equal to 30, FiO2 to titrate SpO2 between 92 to 95 should be adopted for patients with PDA requiring invasive mechanical ventilation. Fluid responsiveness should be re-evaluated using dynamic indices before fluid administration in patient with this physiologically difficult airway who develop hemodynamic instability after tracheal intubation. Continuous invasive blood pressure monitoring and central venous access should be established in patient with the physiologically difficult airway who develop persistent hemodynamic instability after tracheal intubation. Sedative hypnotic infusion guided by clinical assessment of depth of sedation should be employed after tracheal intubation with neuromuscular blocking agent in patient with physiologically difficult airway to reduce the risk of accidental awareness with RICO. Thank you guys.